Okay, thank you for joining us on this beautiful sunny Tuesday afternoon where we never get rain in Southern California. This is a talk about things that come up pretty frequently in our office visits before people have surgery. There's a lot of anxiety around postoperative pain, and it's not a simple topic to address by any means. Pain is actually a fairly complex topic that most of us as surgeons have to deal with, and we spend a fair amount of time talking to patients about this. And it's not just about the expectations after surgery, but some strategies. And as you'll see, hopefully, as this talk goes on, that we really try and take a multidisciplinary approach to treating postoperative pain. This is not meant to be an academic talk. It's a very general overview. And the basis of this talk is to really deal with acute surgical pain and not chronic pain management. They're very different things. And the goal is to treat your surgical pain and not turn you into someone that needs more of a chronic solution after surgery. One thing I will tell you is that pretty much every oral medication that we have that does treat pain has trade-offs. So I use this saying pretty much frequently. There's no free lunch when you're taking care of pain. Everything that we prescribe, almost every modality that we do, has its potential downsides, and it's a risk-benefit profile. There's been a lot of talk about the opiate epidemic and whatnot, and that's a very real epidemic. This talk is basically geared at both hip and knee replacement and partial knee replacement surgery. It doesn't really address shoulder replacements and the smaller joints, though the same strategies often apply. In terms of how pain goes, this is sort of how joint replacement surgery looks. You have the lesser of the painful procedures, such as hip and partial knee replacements, going towards the more intense pain procedures, such as a full knee replacement. I think most people who have done both, it's not a across the board thing, but most people who have had both their hip and knee replaced will tell you that knee replacements are significantly more painful. Couple things to remember about pain. Pain is a normal response that we have to various types of stimuli. Pain's meant to be, we've evolved to have pain be protective, allow us to heal. So when we talk about protection, it's like touching a pan of a hot pan on the stove and pulling your hand back. You feel that immediately. You have an automatic reflex to that protective pain. It also allows for healing. When we break our bones, they hurt because your body really doesn't want you to move that arm, because the lack of mobility or the lack of movement between those two broken bones is what really stimulates bone healing. It also allows for healing after surgery. When we make an incision or whatnot, we don't want you doing too much, because then you can open your incision up and have other issues. So, pain is a protective mechanism that we have. It also tells us something's wrong. If you start having pain in your low back, it could tell you that you have a pinched nerve, or, some very odd pain sensations come up. Often tumors cause very vague types of pain. It's a way for our body to alert us that something's going on. So again, pain is not necessarily a bad thing. It's just not something that's fun to deal with when you're dealing with postoperative pain. So it's a very spectrum. Pain is also on a spectrum. Everyone has different responses to pain. Some people get through surgery, they never take a single pain medication or whatnot. And some people have severe pain, and that really depends on a lot of factors. Exposures to opiates in the past, chronic opiate use, And just there's a genetic component too. So again, pain is complex. What causes pain? Things like mechanical injuries, inflammation. Inflammation is a common thing that we talk about. So it's really kind of interesting to see people when I ask them about whether or not they take anti-inflammatories. Most people feel that anti-inflammatories don't do anything for them. A lot of the times I hear, oh yeah, I tried that for a couple of days and it didn't do anything. You know, inflammation is a chemical mechanism of causing pain. It's your body's way of responding to certain types of stimuli. You get an inflammatory response, and it's the chemical reaction from inflammation that goes on to cause pain. There's also mechanical trauma, surgical trauma. So, you know, it depends on what's causing the pain. You know, when we treat knee arthritis, we commonly prescribe anti-inflammatories because what causes pain in knee arthritis is a chemical reaction. It's an inflammatory response to a mechanical stimuli within the body. Again, and we've talked about extreme temperature and then pinched nerves. You know, nerves don't like to have anyone that's had a pinched nerve in their low back or dealt with sciatica knows that this can be one of the worst types of pain. Neurogenic pain is pretty awful, and you see it a lot in people who have pinched nerves in their back, or even things like diabetic neuropathy. So what have we used in the past to treat pain? So they discovered the opiate receptors, I think, in the late 70s, and you know, it wasn't long to start to develop. You know, opiates have been around for a long time, but no one really knew how they worked. You know, heroin and whatnot have been around for, you know, hundreds, if not thousands of years. And you know, when Big Pharma got involved here, they started developing oral pain medication. Oxycodone or hydrocodone are kind of short-acting opiate narcotics, and then OxyContin's the long-acting version. And these are different various pain strategies that we initially developed in the 70s, 80s, 90s, and even the 2000s. And these are also the same medications that have gotten us involved, including fentanyl, with the current opiate epidemic. So, you know, before we get into that, the thing that I tell people, and we talk about pain strategies, and we'll talk about things like cannabis later in the talk, but all of these things are a very close cousin to heroin. So when people want more opiates and we try and discourage them, you know, and someone may suggest things like a cannabinoid or an anti-inflammatory, it's not infrequent we get kind of the eye rolls that like, well, you know, that those don't really do anything, or there's a social stigma with taking cannabis, that people often say, well, I don't want to take, you know, cannabis. And my response is, well, would you rather try that or just take the legal heroin? And, you know, it kind of shocks them. So keep in mind that all of these are very close cousins to heroin, which is highly addictive and problematic. So, you know, a little bit about the narcotic epidemic. And, you know, this comes down to the education. So in 1996, the American Pain Society had a meeting where the chair of the American Pain Society called pain the fifth vital sign. And if anything gets caught in the media, it's one of those things. And the four vital signs that we typically use are heart rate, blood pressure, respiratory rate, and temperature. So when people come into the emergency department or they're in a doctor's office and they're sick, these are often the signs that we look for. These can all, you know, elevated heart rate, elevated blood pressure can all be signs of impending doom or mortality. So it didn't take long for this to catch on. And this is directly from the quote: vital signs are taken seriously. If pain were assessed with the same zeal as other vital signs are, it would have been much better. It would be have a much better chance of being treated properly. We need to train the doctors and the nurses to train treat pain as a vital sign, and quality care means that the pain is measured and treated. The problem is that the 4 vital signs above: heart rate, blood pressure, respiratory rate, and temperature, those are life-threatening. Theoretically, people can die of pain, but it's rarely the case. Pain is something that is generally not life-threatening, though it can make you feel like you want to die. And people got this. A lot of news media got a hold of this. The VA got a hold of this, and the VA was the first ones to incorporate pain as the 5th vital sign. And then the Joint Commission, which basically kind of oversees hospital accreditations and Medicare, basically released in 2001 standards related to the assessment and treatment of pain. And the whole point of doing this is to get practitioners to pay more attention to pain. But this had unintended consequences. So, we're being held as practitioners liable in the face of patients and the media, that if we're not adequately treating pain, then we're not often doing our job. So what happened, it didn't take long for people to come into a primary care doctor's office or an orthopedic surgeon or a surgeon's office and be like, look, I'm having a lot of pain. What they would do is, instead of giving them the traditional things like an anti-inflammatory or Tylenol, they would give them a narcotic, because narcotics have this feeling of euphoria. They theoretically do treat pain, and people would be happy. And then they keep coming back for more. And then Big Pharma got involved. And my dad's a retired orthopedic surgeon, and when OxyContin came out in the early 2000s, he had drug reps coming in telling him that this stuff was non-addictive and it's great for treating pain. All of these things led to just a disaster. And hospitals and physicians started having really their reimbursements tied to pain scores and Press-Ganey scores, and questions like, was your pain adequately treated well? And the fear was that if you didn't give people exactly what they wanted in terms of their narcotics, that they would be paid less. It turns out that that's not necessarily true. It's more of like how you assess pain. But the fear was that, and it was a very valid fear, that, and then you have all these things like Dr. Google, Google rating systems and MD Vitals that rate providers based on their treatment of pain. And, practitioners basically caved, and they said, like, well, look, I'm being held to the standard. I don't have a lot of other options in terms of treating pain, so I'm just going to give them narcotics. And you can see how this would quickly spin out of control. So, to make a long story short, in 2016, the American Medical Association, with the opioid epidemic, started to push to have pain not be the 5th vital sign. And in fact, there's been a huge reversal in the media, in a lot of state legislatures, including California, to really monitor physician prescribing. And, when we prescribe narcotics now, we have to log on to a website. We have to look to see what the patient's prescribing history is. We have to see if they're, doctor shopping for more things. I mean, it's created a headache for us, for sure. And what I've seen in my practice since I've been here, and I've been here almost 10 years, the amount of narcotics being used after surgery is precipitously plummeted. So, a little bit more about opiates. It is a great tool for treating certain types of pain. So acute post-surgical pain, taking a narcotic for, a couple of days after surgery when you're really uncomfortable, it does help with that breakthrough pain. The problem is it's highly addictive. And when, there are studies that show that if you take it for more than 1 or 2 weeks, the chances of you getting addicted to a pain medication do go up. When you truly have post-surgical pain and you take a narcotic, they can be very effective and fairly low in terms of its addiction potential. But, when you're taking them 6 weeks, 8 weeks, 3 months out, your chances of being addicted go up significantly. We watch that. Not only that, I think it's the Star Trek thing where people think we can wave a magic wand and get rid of pain. And opiates don't really get rid of pain. What they do is they really take the edge off. So if you're living up in an 8 or 9 on the pain scale, 10 being the worst, narcotics can help bring that down. But anyone that's been in my office or talked to me they know that I really do not like narcotics. It's a necessary evil, and that's how I look at it. And narcotics have a lot of side effects. They cause mental status issues. It can make you definitely delirious. It gives people that feeling of euphoria, and if you have a little bit of dementia, that feeling of euphoria actually turns dementia into an exacerbated form of dementia that hopefully is transient. It can cause respiratory depression, and this is what people die from. They die because it suppresses the central nervous system's willingness to breathe. It can cause their opiate receptors in the gut, and it can cause you to be constipated and cause you to be nauseous. The other thing is that a lot of people think that they have an allergy to narcotics because it causes itching. That's a very common side effect. And what I would say is to be very careful about what you report as having an allergy, because these are common side effects. They're not necessarily allergies. Before you report it, I got, when people say they were itching with Percocet or something like that, that's a fairly common thing. You don't want that to go on your medical record as being a true allergy if it's not, because, when you really need it, when you have a crisis and you're in a pain crisis for whatever reason, you want to be able to use these tools because they are effective tools when used appropriately. But again, narcotics are a terrible thing for chronic pain. Some people take it and they think it works well, but we'll talk about why that is. So how do opiates work? So, this is a little piece of nerve tissue. This is essentially a cell wall, a nerve cell. And what happens is you have these nerve tissues and their cells that have these little pain receptors. And your body produces these normal pain modulating units when it senses pain, either to a chemical or a physical response, that basically bind to these receptors just like this, and it causes pain relief. Okay, so what happens with opiates, they've designed these opiates to where they'll fit in with this chronic pain or this pain receptor, and they'll cross the blood-brain barrier, and you get pain relief with these opiates, and it's pain relief in the sense of euphoria as well. What happens when we start taking opiates for a long time, so this is just someone just got a dose of morphine after surgery, they get this pain relief. But when you start to use these a long time, what happens is your body upregulates these pain receptors. Okay, so it upregulates these pain receptors, and what happens is that you have less pain relief. You have the same number of let's just call this the same number of oxycodone molecules or morphine molecules, but you need to have all these receptors saturated to get that same pain relief. So what happens is that you don't have enough opiates now to give you adequate pain relief, such as what happens here. Then you need to take more opiates to saturate those receptors. And it's a vicious cycle, because the more opiates you take, the more receptors you make, which means you need more opiates, and so on and so forth. So the moral of the story with opiates is that, they're good in short duration, but when you start upregulating your pain receptors, it can be a little bit more tricky. So, it definitely helps. These things definitely help take the edge off of acute pain exacerbation, such as in surgery, or if you break a bone. It's not an uncommon thing to have it for a very short term. It's not a long-term pain strategy to take these things, and there's a lot of issues related to opiates. So, the pain pathways that we have, there are other pathways, and this really only addresses one of them in a fairly highly addictive way. So what we've done in surgery, and this has really become the mainstay of treatment in our practice here at Eisenhower Desert Orthopedic Center, is a multimodal pain strategy when we do joint replacements. So the multimodal pain strategies start in the preoperative period, and then we have pain strategies that we use in the intraoperative and perioperative, like the day of surgery strategies, and then what we do postoperatively. So we know that when people have an initial block to pain response, it definitely helps with lower pain after surgery. So what does that mean exactly? So the one thing that doesn't work that well is taking opiates before surgery. For whatever reason, this seems to not be all that effective. You need a complete block of sensation to the central nervous system. And how do we do that? Well, before we get into that, the things that we do preoperatively is if you're coming into us and you've taken narcotics for, sometimes months, if not years, even weeks, we really want you to reduce the amount of narcotics that you're taking. It makes pain after surgery definitely difficult to take. The people who come in before surgery on narcotics require much higher doses of narcotics to treat their postoperative pain for reasons that we talked about. Some things that you can do on your own is your fitness. People who are more fit and in shape tend to have less pain. This is something that we don't totally understand, but I think it has to do with circulation and being able to deal with the postoperative inflammation better. And then there are some desensitization techniques that we do. So, what is a desensitization? So this is something we started doing about a year ago at Desert Orthopedic Center. It's called iovera, and what it is, it's cryotherapy. There are two types of way to desensitize nerves. There's radiofrequency ablation, which the pain management doctors often use for chronic pain. So if someone's not a good candidate for knee replacement, they have medical issues, what they'll do is they'll go in and they'll ablate the nerves around the knee. And that does seem to make a difference with chronic knee pain associated with knee osteoarthritis. So we took that a step further, and we are using this to treat perioperative pain. So people come into our clinic 1 to 2 weeks before surgery, and what we do is we have this little gun detailed in this, as shown in this picture here. And what we do is we go around the anterior aspect of the knee and we basically freeze those nerves. So we paralyze those nerves. And that nerve paralysis basically is blocking that initial pain response when you have surgery. So people just don't sense the pain nearly as much. It really only works on the knees in front of the pain, in front of the knee. It does not really address the nerves on the backside of the knee, and this really helps reduce or take the edge off of postoperative pain. It doesn't eliminate it. So, I was talking with a company, and their CEO or their some executive in their company had a knee replacement, and he had iovera done before his knee replacement, and he was really pretty upset because he didn't have complete elimination. He felt that he would come in and have no pain after his knee replacement. It doesn't really work like that, but it definitely takes the edge off of your postoperative pain. And what we're seeing is it seems like people are using far fewer narcotics when we use this. I will tell you, it's a controversial thing. We don't know a lot about it. It's not covered by insurance. It is an out-of-pocket expense for the patient. And there can certainly be issues with this. So the pros of doing this, it seems to make a difference in many patients. We've been doing it for about 1.5 years. It seems to reduce the amount of narcotics that people are taking postoperatively. Far fewer prescriptions. People are taking them for much shorter durations. The cons is it's expensive. It only addresses the pain in the front of the knee. It requires an extra office visit, which is kind of and it can be a fairly long office visit, probably an hour to do this procedure in many cases. And it's dependent on many factors. The people that we know who are on chronic opiates really don't have nearly as good a response with this as they do when they're not on narcotics before. And that's not something we totally understand. And you can also have rebound pain. We've had a couple people who actually, we go in and we freeze these nerves, and then they come back and they're actually in more pain because nerves don't like that trauma either. It happens relatively rarely, but it can happen anywhere between 2 and 5% of the patients who get it. And any kind of nerve pain, as I said before, can be fairly painful. So we have seen that happen 1 or 2 times, but it's just like getting a knee injection or anything like that. Occasionally, it just doesn't go as planned. So that's kind of what we've been using for the preoperative side. Intraoperatively, We do many things. So a mainstay of treatment for pain is an anti-inflammatory and Tylenol. Anti-inflammatories such as Celebrex, Toradol, Meloxicam, we give these preoperatively when the patient's getting ready for surgery the morning or the day of surgery. We also give people a shot of a steroid. So steroids work as an anti-inflammatory, okay? And we try and avoid the narcotics. People who get narcotics the day of surgery seem to have more of an issue with pain and other complications related to that. Spinal anesthesia, we always want people to try at least using spinal anesthesia because it blocks pain completely in the lower extremity. So that initial blockade of pain seems to really get people over that hump of the initial pain response. When people wake up and they're screaming in the PACU from pain, and we give them large doses of narcotics because that's what we do, they tend to have pain longer and require more use of narcotics in the postoperative period. So we try and avoid narcotics the day of surgery. And for that reason, so what happens, why we don't like general anesthesia, and we talk to people about spinal anesthetics, and a lot of people don't like that idea, the thought of a needle going into the back, it really freaks them out. But the problem with general anesthesia is it requires narcotics to treat your pain while you're under. So what happens with the general anesthesia is you get something that puts you to sleep and keeps you from moving, but it doesn't block any of your pain receptors. So you might be asleep, but you can feel everything that's going on. And as you can imagine, that's not very pleasant. So that's when anesthesiologists will use powerful narcotics such as fentanyl to block those pain receptors, okay? The other thing that we do the day of surgery is peripheral nerve blocks. So there's several different types of peripheral nerve blocks. We do one in the front of the hip, and it blocks some of the nerves around the joint itself. They seem to be relatively well, they seem to work relatively well, but their big downsides is occasionally you hit the nerve at a point where it temporarily causes muscle paralysis. And that's a fairly anxiety provoking thing if someone can't flex their quad for a day or a day and a half. You don't know if that's a temporary thing. People, if you don't have function of your quadriceps, you can't extend your knee, you can't put weight on it. It can be a big problem. And then the knee, there's several types of blocks that we do the day of surgery. You can block the front of the knee, the back of the knee, the side of the knee, all sorts of things. And those are temporary blocks that usually last for about 24 hours. We do have a system that we started using a couple of years ago called the on-cue pump. And what that does is it's a catheter that goes in at the time of surgery, and it sits above your knee, and what it delivers is a local anesthetic like Marcaine, or what the dentist uses to numb you, around the peripheral nerve, the big peripheral nerve in the front of the knee. And this will give you about 72 hours worth of relief. Remember, it's the success for treating pain is getting you over that initial pain hump. And this thing seems to have been very, very good for many people. But just like anything, there's no free lunch. These things, Eisenhower does not have an outpatient prescription pharmacy, so we cannot legally give these to patients. They have to purchase it through a third-party pharmacy, which we help arrange. We can't supply them because of the way the state of California regulates hospitals. The other issues is they can leak. Sometimes you do have a catheter coming out of your leg, and those catheters can be prone to having problems. But most people who get these say like that thing was great until it came out 3 days after surgery. But by that time, hopefully you're on the downward slope of a lot of pain. It's really only for knees. It's not for knees and hips. Or it's not for hips, excuse me. The other thing that we do is we limit surgical trauma. So a lot of postoperative pain is directly related to the inflammatory response that we have as a result of surgery. So you go in, I do my knee replacement on people. If you're sitting in there ripping muscles apart and really, really being hard on the soft tissues, that creates a much larger inflammatory response, which takes longer for that to calm down. I will tell you, the adoption of the robot in my hands seems to have made a much bigger difference in terms of people getting over that pain. This is a less invasive way to do surgery for us. We really feel that way. Several of us use this here. It doesn't require nearly a number of retractors, or retractors are in there pulling the soft tissues out of the way. This is a very precise way to do a knee replacement and a hip replacement. I will tell you that it's still very controversial in the orthopedic world. You may hear what I say, and then you go talk to someone else and they don't think that that's necessarily true. And I will admit that it's controversial. However, more and more data is coming out to support my viewpoint, which I'm happy about. The other thing is this also leads to less time in the operating room. It's less time that your tissues are under duress. So when I look at this and exactly what I've been saying, this paper came out about a year ago, and it basically, they saw a significant, we have these ways to they're markers of inflammation, and people who have had robotic assisted knee replacements tend to have a lower inflammatory response, a week out after surgery. So we're seeing people, you get this initial inflammatory response, but it's lower, and people's inflammatory response seems to die out. Now, when you look, 6 weeks, 8 weeks down the road, that inflammatory response is normalized anyway, but you're just not nearly in pain nearly as long. So I think that that's why we're seeing people, and that's why I put it in the perioperative thing. I do think that there is something to it, though, like I said, it's highly controversial. So postoperative pain strategies. We do give people narcotics, as much as I dislike them, because we need people to have a rescue. So we use this for breakthrough pain. But I will tell you that it's a better strategy to use things like anti-inflammatories and Tylenol, and neuromodulating agents. The anti-inflammatories and the Tylenol help block the central nervous system, the inflammatory response, and the neuromodulating agents such as gabapentin or Neurontin kind of help block the nerve stimulation, and then the narcotics are sort of left over. And then there are non-pharmaceutical strategies. Cold therapy. Cold therapy works extremely well. If you've had your hip or knee replaced here, you know that we are often, pushing ice and whatnot on people, saying it does make a difference. Compression and edema control. So swelling is a form of inflammation. So your leg swells up. Some people come in, it's not uncommon, you can't put your shoe on for, 3 to 6 weeks after you've had your hip or knee done. And that's getting control of the swelling after surgery. And then careful therapy. It's not uncommon where people are doing well the first week after surgery, and then they have an overzealous therapist that pushes them a little too hard. The only thing I personally like people working on their first, several weeks after surgery is getting your range of motion back in your knee and walking more normally. If you have a therapist that tries to get you to do squats post-op day 5 because they think you're doing well, you're going to pay for that. Muscle strengthening it's not time to do muscle strengthening 2 or 3 weeks after surgery. You want that initial inflammatory response to calm down. And you think about it, like if you go to the gym and you lift, you do biceps 3 days in a row, you're not going to be able to move your arms. They're painful, they hurt. You have to let your body recover from the initial inflammatory insult from surgery. Narcotics, as I've said, they're okay for short duration after surgery. One of the guys I trained with was from Ghana, and when you get your knee replaced in Ghana, they give you 1 shot of morphine and they put you on Tylenol the rest of the time. That's a cultural thing here. We way overprescribe narcotics, and what I tell people, it's true. You'll feel better the quicker you get off the narcotics. You won't have nearly as much nausea if they affect you that way. Generally, the faster you get back to your kind of normal day-to-day routine seems to make a big difference. Narcotics are a necessary evil, though. They help people with that acute surgical pain that the other things aren't touching, but it's really important to limit them. Tylenol works. Tylenol is a great pain medication. People often blow it off because it's over the counter and they don't think it works. And they, you know, I'll often ask people if they're using an anti-inflammatory, and well, I use Tylenol, and Tylenol is not a good anti-inflammatory. In fact, Tylenol is not even good for treating hip and knee arthritis. It's been shown to really not be that largely effective because it doesn't treat the inflammation that comes from that. It's relatively safe. The maximum dose of Tylenol is usually 4,000 milligrams a day. However, in this patient population, we generally like to stick to about 3,000 milligrams. And I usually direct people to just follow the directions on the back of the box, with the exception of going to 4 milligrams, because people have liver issues and cause liver damage in really, really high doses. And it works. And it seems to have an impact on the central nervous system pain pathway. But again, this is not an NSAID or a non-steroid anti-inflammatory, which is like ibuprofen, naproxen, Celebrex. Then here come the NSAIDs. So Celebrex, ibuprofen, meloxicam, these are kind of my go-tos. I like Celebrex. It's been shown to be one of the safer anti-inflammatories. It has more GI protection than the other anti-inflammatories. And that means that they're less prone to ulcers. It doesn't mean you can't get an ulcer with it. Celebrex does have a black box warning. It's been shown to have significant cardiac side effects in some patients. However, that's a very, very low percentage. And when you look at all of the other anti-inflammatories, they seem to have other bigger side effects that can have an impact. And remember, I said there's no free lunch, and that's the thing you got to remember. You have to monitor your bowel issues and your bowel movements very closely when you take these things. The biggest concern that we have is when people are taking anticoagulants such as Eliquis or Coumadin or even aspirin, and you're on high dose Celebrex, is it can cause a stomach ulcer that leads you to bleed. I always tell people to help avoid those side effects or those complications. You really want to take these with food and water. Anti-inflammatories can have a negative impact on your stomach, and they can have a negative impact on your kidneys. So you really, really want to stay well hydrated, especially out here where it gets hot in the summer. And not infrequently do we have people take antacids with them, such as Pepcid or Prilosec. Now we have the neuromodulating agents. These kind of help the transmission of pain, the gabapentin and the pregabalin, and whatever we prescribe. I like Lyrica a little bit better, but it's highly dependent on your insurance provider and what's cheaper. So we'll either use Lyrica or Neurontin. And again, it helps block the pain transmission. And we're using it more and more. A lot of problems that people have after surgery or postoperative night pain, and I'll talk a little bit more about this as well. But we use it. I'll often have people take it at night because they can be somewhat sedating a lot of patients. They can cause delirium as well. So if you're having a spouse that just had a joint replacement or whatnot, or they were just starting on this and they're acting funny, it's very possible it's either the narcotic or the neuromodulating agent, such as gabapentin or pregabalin. So here's a little bit about the evidence. I've talked a lot about the power of Tylenol and anti-inflammatories. So the Cochran Collaboration really looks at many studies looking at postoperative pain and what's been effective, and protocols. And here's what they found. So this is the number needed to treat. So the way you want to look at this data so it says 4 point. So let's look at oxycodone at 15 milligrams. That's a pretty healthy dose of oxycodone. Typically we prescribe 5 milligrams, and we'll have people take 1 to 2 tabs. So 15 milligrams is a pretty large dose of oxycodone. So the way you have to look at this is that you basically have to treat 46 patients to have relief in 10. Okay. So when you look at ibuprofen and acetaminophen, when you take those doses outlined there, you really only need 16 patients to get effective treatment of TED. So you can see that these things are effective, but people think because they're not necessarily always a prescription that they're not effective. And I will tell you, that's not what the data shows. But, you know, we're doctors and people have Dr. Google and they think they know because they had a friend that did this and that. And I will tell you that many studies have shown that when you take an anti-inflammatory such as Celebrex with Tylenol, it's as or more effective than an oxycodone. And this just sort of highlights that. So I will tell you, based on what I just showed you, Tylenol and a good anti-inflammatory seems to be better than opiates. I know it's crazy, but look, you know, the Cochran Collaboration has really shown that to be the case. Now, there are people that can't take anti-inflammatories. They've had ulcers, or they have Barrett's esophagus, or it causes high blood pressure. You know, and that's unfortunate. It's not something that we can do for everyone. But you know, the general public, for the most part, can tolerate both, especially in short durations. You take it 2-3 weeks after surgery and you stay well hydrated, take them on full stomachs. It's usually not too bad. And we've already talked about with Tylenol, you really have to watch people with liver disease. So alcoholic cirrhosis, liver cirrhosis, whatnot. You know, Tylenol is not always the best option for that. So then we have cold therapy. You know, people can buy over-the-counter cold packs or just bags of ice. The issues with doing these things is that they can really, they can cause frostbite in your skin. So that's something you got to keep an eye on. You don't really want to leave ice on for more than about 15 or 20 minutes. And the problem when we do knee replacements, you definitely have nerves that get cut in hip and knee replacements where you don't have full sensation in parts of your knee. So you have to be careful because you could leave an ice pack on there for a day and you don't even know that you're doing damage. We started using cold machines about a year ago. My practice does sell them. I always tell people I feel like a used car salesman when I tell them about them. But the difference between the cold machines that we use and the ones you can buy on Amazon is that we know that the ones that we sell are generally safe to leave on all the time. The other great thing is they add compression. So remember when I talked about things like edema and just generalized swelling after surgery, these machines help limit that because they give compression as well as cold therapy. And you can sleep with these on. Some people can tolerate them, some people can't. Heat can also be effective at treating pain, but you have to be very careful with this. Just like ice can give you frostbite, heat can burn you, and there's not always a great way to regulate things like warming blankets. Sometimes they get too hot, and again, because you have some numbness around your knee or your hip where the surgical incision is, you can't always feel that it's causing problems. So how else do we treat edema? Elevation. We tell people you want to keep your leg elevated above the level of your heart. So if you've had a hip or a knee replacement, you like watching golf, you know, you're sitting there watching golf or whatever TV show or reading a book, you want to keep your leg elevated above the level of your heart. It's not always easy to do, and it's not always something you want to do for a long time. But a lot of people will go to bed, they'll keep their leg elevated while they sleep, and then they wake up and shockingly the edema is down. And then they get up and they move around and it comes back. It's dependent, you know, water rolls downhill, so does the fluids in your body. And then there's compression. So there was a nursing initiative actually before I got here 10 years ago where they got rid of all the compression stockings. You know, compression stockings work really well if you have healthy skin. The problem with things like TED hose and putting them on everyone is you get some patients with that paper thin skin, and these are very hard to put on. And you can imagine that you have someone with a fairly rigid stocking, you pull it off, and sometimes the skin would come with it. So it's really largely been eliminated in the hospital. But I always encourage people, if you have healthy skin, to go out and buy compression TED hose. And what you want the ones just shown here, the ones that go above your knee. If you get the ones that stop right at your knee and you've had a knee replacement, your knee is going to look like a big cantaloupe, and then you're going to have this chicken leg below it, and you're not doing a lot of the effects. So you want to have the compression stockinettes that go above your knee, and you can get these on Amazon or CVS. Generally a medium compression. Sometimes you have to mess around with what fits. If you want to be fit by them, you can go to occupational therapy and they can give you some idea of what you need. And then the ice machine that I talked about also adds the compression. So physical therapy, we have a love-hate relationship with physical therapy. They're great for certain things, but I will tell you, probably a couple of times a month, I'll get a patient who is doing great with their knee replacement, and then they had an overzealous therapy visit, and then they're living in their bed for 2 days. They think something went wrong. You have to go careful and slow with therapy. Like I said, the first month after therapy, you should really focus on getting your range of motion back and your mobility back. You have no business working on things like strengthening your quads or doing this or trying to do the splits, whatever they have you doing, walking uphill. I don't know, let's not spend a lot of time on the stairs, 2 days after surgery, because you're going to be in a world of hurt. So be careful. Therapy is great, but be careful of the overzealous therapists. So here's something that I mentioned before. CBD and THC. We live in California, and California, you don't need a medical license, or you don't need a medical prescription for cannabis. We don't really know what we're doing here, and I'm just going to tell you that right now. I will tell you, a lot of patients anecdotally feel that it makes a difference. A lot of people have told me that it makes a difference with helping them sleep. I think it's safer than opiates. People will take a Percocet before they go to bed, and then they go to bed. Percocet doesn't really often impact sleep that well. So I tell people, I'm like, look, I'd rather have you take medical cannabis or try that to see, or even just wherever you buy it. But in terms of dosages and whatnot, it's really hard for me to tell you what to use, because we don't really know. What I will tell you is that people that are using this chronically, when they come in for surgery, it can make you less sensitive to a lot of the anesthetics that we use the day of surgery. So it does have negative side effects. Here's one paper that supports there's a reduced rate of postoperative pain in patients who self-report postoperative cannabis. Studies are needed. That's kind of how people say that they have less postoperative use of narcotics. That's the POU, postoperative use of narcotics, in people who use perioperative cannabis. So whether they're trading the Percocet to help them sleep or the cannabis, that's what they're likely doing. Both likely don't make a big difference in terms of pain, but you might be able to sleep better with both, but you're having a less addictive drug that you're taking to help you with that sleep. Again, very careful to tell you what to do. And there are recommendations are made for surgery. This is basically stating that this paper basically guides us to help make recommendations. You can see while cannabis likely has some therapeutic benefits, it must be treated as a controlled substance, because it is, it has a cognitive impact when we take it. So we're learning more about this stuff. These are all recent articles. This one was from 2021. We really don't know, and I'm not sure how well we're going to know or how quickly it is, because there's not a lot of money in pharmaceutical companies to study cannabis right now. There is for cannabis companies, but they're not set up. So, the bottom line when it comes to cannabis, we don't know. Whether you talk to me about what to get, or whether you just go to one of the dispensaries and see what they recommend, I can't tell you what's better, because there's very little guidance on this. Postoperative pain. So a lot of this comes down to counseling. Something that I always try and ask people about when they come in is what the night pain's like. They'll come in at their 3-week visit, and I'll walk in, and the first question I often ask patients is it safe for me to come in, or do I need a bulletproof vest? Because people can have a highly range of an experience 3 weeks afterwards, within the first 3-4 weeks of surgery. But about 80 to 85% of patients have significant night pain. You know, they're doing okay during the day, and when the sun goes down, the boogeyman comes out, and it really keeps them up, and they have a hard time with that. I think it has to do with more of an inflammatory process. That's my own personal theory. That, you know, you're walking around, you're moving around, the inflammation in your leg is being turned over because you're moving your knee or your hip. And when you go to bed at night, it's not moving anymore. It has less turnover in the inflammatory molecules because your body's kind of going to sleep and not moving nearly as much. And the inflammation builds, and that can cause the side effects from that. And, you know, it's not always pain. Some people just get restless legs. They get stimulated at night. There can be a various set of reactions. And I will tell you, trying to educate people on postoperative pain is important. You know, we have educational materials that we give. We let people know, you know, it's really, it's always kind of, I wouldn't call it irritating, but it's one of those things that people come in at 3 weeks surgery and they tell me, like, why am I still in pain? It's been 3 weeks. And I'm like, well, I did let a small bomb off in your knee, and, you know, this isn't Jiffy Lube. Your body needs time to heal. That's what this comes down to, is that, you know, you have to let your body heal, and pain is a way that your body is trying to tell you that it's still healing. So if we did your knee replacement and you instantly felt better 2 days later, but you need time for your incision to heal, think about it. You'd be like, well, I feel great. I'm going to go up the bump and grind. And while you're going up the bump and grind, because you don't have any pain, you split your incision open. You know, you haven't healed, so your body needs time to heal. And we try and address pain in multiple areas of our system. So we have a preoperative class that's either live or virtual. We have two options. We give people educational materials. We give you a joint replacement book. And then we try and talk about it during the perioperative visits, like, you know, your pre-op, and then especially post-operatively, because it can be a very discouraging and depressing thing to be in pain and not to be able to sleep. And we realize that, you know, and my job is to let you know that's normal, and we'll get better. Again, I can't emphasize this enough, that if the faster you get off your narcotics, you'll feel better and you'll have more energy. It's very, you know, along that goes with pain is that post-operatively, people just have a very large sense of fatigue after surgery, major joint replacement surgery. You know, it's a very common thing that we do see. And try and transition off the narcotics and stay on your anti-inflammatory and your Tylenol. Night pain, again, opiates can be very stimulating, believe it or not. You know, people will use it to go to bed, but it's just like drinking alcohol. You might fall asleep, but you're going to wake up and you're going to have a hard time. You know, alcohol for me wakes me up, so I try not to have cocktails at night because it just keeps me awake. Benadryl can be an effective way to treat night issues and help you get some sleep. Ambien's kind of the same thing. They all work marginally well. I will tell you that. We used Lyrica and gabapentin at night. Again, there's no silver bullet here. If I could find the answer to night pain, I'd win a Nobel Prize. Ice, elevation, all of these things help. A CPM, that idea that when we go dormant at night and the inflammation builds, you start to use that CPM, a continuous passive machine, which I generally never prescribe them because people think it helps get your range of motion back. It really doesn't. These things become tripping hazards and they have other issues. But, you know, thinking about it, it may be an effective way to treat night pain. And because it's moving your knee while you sleep. The problem is that you're strapped into this machine that's moving your knee, and a lot of people don't like that sensation, and they have a hard time sleeping anyway. You really want to start a bedtime routine after a joint replacement. You know, get a cup of chamomile tea, you know, read something, kind of make yourself tired to try and go to bed. And there has been some people using an antidepressant such as amitriptyline, which I'm very hesitant to use just because that's not something typically in my prescribing practice, and it can have other side effects, especially with the older patient population. So in conclusion, you know, we really try and approach postoperative pain management in a multimodal approach, really try and avoid narcotics for the long run. The mainstay of your pain treatment should really be anti-inflammatory medication and Tylenol. Cold therapy is great. Most people who buy the ice machines can't say enough great things about them. They really think that those are lifesavers, and the night pain will eventually get better, though it may take several months, like 3 or 4 months. All right. Thank you.